And so with that, I'm sure most of you are aware, comes some cost. A physically taxing job, dysregulated sleep system or sleep schedules, high stress environment, and guess what? Her belief and understanding in pain is rooted in her profession and what she knows and loves to do. And her belief as a nurse is that if something hurts, A, I need to take medicine to make it feel better or for it to go away, or B, something is broke and probably needs fixing. Now, many years ago, Debbie gave birth to Emily, her firstborn. And it was then that she experienced her first lasting bout of back pain. Severe to the point where it was a burning sensation and crippling. It would almost take her breath away. Anytime it hit, it paused her in her tracks. It was getting to the point where she was getting quite fearful and concerned about what it is going on. And so then the fear kicked in and she started to reduce her meaningful activities because she was fearful. Now, like many cases of low back pain, to Neil's point, is that they usually will get better, right? Over time, it gradually will get better and people are able to recover. Now, she's a new mother, so for her, she's managing and balancing the threats in her life. The priority is the safety and the well-being of her baby and trying to nurture and love Emily versus the back pain that she's experiencing. I'm sure the parents in the room can relate, right? Once a newborn comes into the world, sleep schedule out the window, you're not sleeping as well, self-care goes probably through the roof, and you're just a little bit more stressed. So for us, it makes sense why the back pain probably persisted. Now, it's important to remember that her pain is rooted in her understanding of it as a nurse. If something hurts, I should take medicine and it will feel better, or something must be broke and needs fixing. So several months pass and the pain persisted. Concerns and fears continue to rise, especially ready to return to work. She's getting back to go to work. So she visits her PCP. Now, her PCP, like most, has a busy practice and extremely well-intended. She wants to make sure that she does right by Debbie and gives her some relief. So, with this strong desire to give her some relief, she prescribes her hydrocodone. Now, she knows Debbie is a new mom, and she does not investigate the pain further. But, I mean, why should she? It sounds fairly straightforward. Low back pain after having a baby. Now, this is a very pivotal part of Debbie's story. Because her pain sounded relatively straightforward, her PCP did not form a detailed physical exam, did not thoroughly assess for appropriateness for the use of medications, did not refer her to conservative care, and also did not assess for risk factors for the development of substance use disorder or opioid use disorder. And you see there are certain genetic and environmental factors that increase one's susceptibility to use disorder. One of the most prominent ones is a personal or family history of use disorder. Now, Debbie's father was an alcoholic. Debbie herself had previously used marijuana in high school and in college, so she had a history of substance use. Another big factor is mental health. Depression and anxiety increase the risk of developing substance use disorder. Now, for Debbie, she had both, which was previously controlled with marijuana, but then more currently was being controlled with a benzodiazepam prescribed by a psychiatrist. Environmental factors that increase the risk for use disorder is ACEs, adverse childhood experiences. And what this is physical, emotional, or sexual abuse or trauma in your adolescence, in your developmental stages. Other forms of ACEs are living with someone who's been incarcerated, living with someone who has suicidal ideation, living with someone who has a use disorder as well. These are these environmental and genetic factors that increase susceptibility to use disorder. Family dynamics also play a role here. If your parents have been divorced or separated, or there's some degree of isolation, these two fall in the realm of adverse childhood experiences or adversity, which increase our susceptibility to use disorder. Now, I ask you again, why would her PCP investigate these things, right? To Neil's point, it's low back pain. It'll get better, right? And maybe we don't know the exact treatment to do, but clearly hydrocodone is not the way to go. Now, fortunately for Debbie, her pain was able to get manageable, and she was able to return to work. And what would happen is on particularly busy days and stressful days, her pain would flare and she would soothe by taking a hydrocodone, some left over that she had from her prescription. Now, several years have passed, and now Jack is born, and guess what? Her pain returns. Now, for us, this makes sense, right? Decreased sleep, decreased self-care, reduced physical activity, increased stress, and a strong neurotag for her association with the association of pain and childbirth. For Debbie, an all too familiar experience, however, this time it was harder to manage. Her sleep also had been progressively getting worse over the years because her husband had developed sleep apnea. And obviously, being a mother for Emily, she's addressing additional stressors in life. Now, with 2 kids, it's harder for her to take as much time off as she could during the first pregnancy, so she has to get back to work sooner. So there's financial concerns and stress associated at this point as well. But hey, she's been here before, and she somewhat overcame it, and she managed it. So she visits her PCP, same story, different time, prescribed hydrocodone again. However, this time, the meds are not as effective as they once were. She now has to take 2 to 3 to manage her pain. So Debbie, like most, are unfamiliar or unaware with the side effects of opioids. You see, the opioids have a strong tendency to develop tolerance. And for those of you coffee drinkers, right, tolerance is an issue in which you may start with 1 cup of coffee to get your day going, but you start to develop a physiological adaptation and tolerance to the substance, so then it maybe takes 2 or 3 cups of coffee to get your day going. Opioids function the exact same way. Opioids have also been linked to produce a phenomenon called opioid-induced hyperalgesia. The hyperalgesia, for those of you that are unaware, if I flick you on the chin with a consistent mechanical stimuli, right, the force is exactly the same, and typically it hurts you maybe a 2 out of 10 pain. I know we hate the number scale, but bear with me. And it hurts you a 2 out of 10. When you're experiencing a hyperalgesic response, that same mechanical stimuli, the same pressure, might be a 5 or a 6 out of 10. The pain is amplified and it's magnified. Now, opioid-induced hyperalgesia has been seen to be present more commonly in higher doses and after prolonged exposure. It happens at the site of your original injury, but then it also spreads diffusely throughout the body. So what ends up happening is that the nervous system or the individual starts to become less tolerant to physical demands, physical stressors, and non-physical stressors. Worst of all, dependence can occur after just 5 days of exposure. Now, dependence is a physiological adaptation, almost reliance on the substance, and it's categorized by experiencing withdrawal symptoms once the substance is removed, once you discontinue use of the substance. So imagine, same thing with your coffee. If you don't have coffee for 2 or 3 days, you start to experience the headache, right? The caffeine headache or maybe the shivers. That's an example of a withdrawal symptom associated to the dependence to that substance, in this case caffeine. You can only imagine the magnitude of the withdrawal symptoms associated to opioids. Now, Debbie's belief and perception of these experiences is similar to most. I must be broken and something needs fixing. Why is it that now I need to take 2 or 3 pain pills instead of just one to manage my pain?
Thank you very much. All right, so we do have a couple of questions.
Sweet.
All right, starting down. Okay, so from Sandy Hilton, what would you recommend those with unregulated chronic pain do when that pain is not well managed instead of a medication when there is no program accessible? The pain is too high to tolerate non-pharmacological options.
So I think are there 2 parts to that question? Question 1 is those with unregulated chronic pain.
You have a lovely program, but it's rare.
Right.
So for those people who are using opioids and have no help coming off of them and can't just go exercise, what would you recommend they do?
Yeah.
I'm going to repeat that real quick for the parties at home and in the back of the room. Is that basically, so in the case when someone is having unregulated pain that is not necessarily responding to non-pharmacological options, what do we do with those people when there's no program like New Hope?
Yeah, that's a great question. I'm fortunate to be connected with this group, and there are multiple resources that I've been able to find of online-based counseling services, as well as online-based pain management services. And there's funding for individuals. I emailed Rajam some resources for you guys. I think she said she emailed it to you guys yesterday, but in that resource, there's resources, at least in the States, there's resources for funding programs, scholarships, sponsorships. If you identify someone who has a need for it, they can get involved there. Beth Darnell has a great book or 2 that are self-paced, self-management strategies, so if you don't have access to the full-blown counseling services. The other thing, too, that I want everyone to know is that, I mean, we're all the pain science people, right? Like most of what is done, yes, is counseling, but we have a role in that with the educational piece in drawing awareness to these things as well that I think is a part where we could step into.
All right, next question coming from Jamie Lowy. Got that. Okay, Marcos, can you speak to the historical racial disparities with opioid use that was seen from the 1960s through 2000, in which people of color could not access care services versus the crisis status that developed once the issue impacted white communities in the U.S.?
Dude, I'm not a sociologist, man. I mean, honestly, I don't even know where to begin, how to answer that question. I apologize. Yeah, we could maybe chat over beers and I could start to think a little bit more clearly after a beer, but I don't know, man. That's tough. Yeah, I don't know. I'm sorry.
We'll touch on that tomorrow.
Yeah, cool.
Awesome. Could I ask, like, if you look at your clinic, do you see a wide variety of different socioeconomic and cultural and ethnic backgrounds, or is it pretty heterogeneous?
Yes, we do. And most of the participants at New Hope are clients or patients are women, but we get all ages, and we do get different socioeconomic backgrounds as well. I think the youngest gal was in her early 20s, and she was a recovering heroin addict. And then we had a gal who was like in her late 70s. So you do get a range, yeah.
Okay, and then we have a question from Sharna. Let me get it. The pain group that you teach, is it a one-time class or is it ongoing? And if ongoing, how many weeks? Do you have any data on the effectiveness and the efficiency and efficacy, I'll throw that in there, of your classes?
So that's a great question, and that's part of this idea. Is everyone familiar with what common knowledge is? You guys familiar with that term? I'm seeing like blank. So common knowledge is you know that I know that you know something, and vice versa, right? So part of what I have to do is I have created a framework, like kind of like an outline, if you will, or overview, of hitting some of these primary topics. On a given week, there could be a new person enrolled, and there could be people that have been enrolled in the intensive outpatient program for 8 months. So there always has to be some redundancy for that reason, but also, guys, these people are on such high doses of opioids, I could tell them my name and 20 minutes later they forgot it. I could tell them something, and 4 months from now, even though I've told it to them or we've reviewed it or we've talked about it, they're like, oh, that's the first time you've told me that or shared that with us. They're doped up on the medication, and we all know that pain decreases executive function, right? If you got pain plus the meds, the disparity is pretty profound too, that we have individuals who are on 50 MME. Remember, 75 MME is 5 milligrams, 15 hydrocodone. We've had people that are on 1,200 MME. I don't even, so to answer the question, it is every week, every Thursday, 12:30 to 1:30, there is redundancy within a framework that I'm working on. My goal for this year is to try to make that scalable so that I could, we could maybe do an online 4-hour course and I can give you guys insight on the things that have been successful for us. The only data that I have is I did measure pain catastrophizing, kinesiophobia, and I measured it pre and post every single session with the framework foundational 4 sessions to establish that common knowledge. And what we found in these groups is that there was intra and intersession changes specifically for their pain catastrophization. And if you guys read in your notes that I sent you guys, that Rajam sent you guys, what you guys will find is that with some of Beth Darnell's work, pain catastrophizing, a score greater than 10 is a risk factor, if you will, of developing opioid use disorder. And it used to be thought that the scores needed to be higher, and there's a paper she did, I think, in 2017 that is probably in there. So I measured pain catastrophizing and kinesiophobia, and there were some successful outcomes with that specifically, exceeding MCIDs, yeah.
Okay, we have 2 more questions. We'll see if we have time for them. The next one is from Michelle Oren. How do you best bridge the gap to your patients who perceive you as unable to relate to their need for pharmaceuticals due to socioeconomic presumptions?
Can we add clarity? Is Michelle here? Can you stand up? What do you mean socioeconomic presumptions?
Some of the patients I've seen that are on opioids, they come from more humble background or a poor socioeconomic class. So I do get the perception sometimes that they don't feel like I can relate to their problems, their pain, their need for drugs because they perceive me in my post as, a PT to not be relatable.
Okay, I'm going to repeat that real quick, and I'm going to summarize. So tell me, give me a if I don't get it right. Is that basically, it sometimes in your practice, there are people who appear to kind of give off the perception that you're not getting it because you're a graduate, you're a PT, you're educated, maybe because you're white, that they feel like you're not getting it. So how do you handle that feeling?
I think there's a couple things that come to mind. One is it's not easy and it's an art, right? It's all about the trust and the alliance with the patient, which is why I think we're in the ideal space. If you're PT, OT, massage therapist, we spend the most time so we can establish that trust. 2, I think, is making it common knowledge and letting them know that no one is immune to this, that this is affecting all levels of socioeconomic status, whether across the world. So in essence, you normalize the pain experience. Well, you also normalize this because in our current state of the world, it is normal to be on prescribed these medications. And I think the other piece too is, oh man, it might have left me. But hopefully that satisfied your answer or your question.
Yeah, it did. So can I ask a follow-up then?
Sure.
With that outcome measure to see how susceptible you are to addiction, when do you introduce it, and do you introduce it more than once to a patient once the rapport has built?
Yeah, so the question is when to introduce the screening tool. So the way that my practice functions is that I personally review screening tools with patients. I don't have them do it on their own in the waiting room. You know what I mean? I literally sit there with them and I ask them, have you ever been diagnosed by a medical provider with cancer, with high blood pressure, with diabetes, with depression, with anxiety? So I review that with them. So for me, I do just a little variant of the tool. I don't use the tool itself because I know what the factors are. So it's built into my medical screening as I'm going through past medical history screening, and I just simply ask if they have a history of use disorder or a family member or friend that has use disorder. And then you've got those two factors plus the age, plus the mental health issues, which are the most predictive. So early on, to answer your question, it's right off the jump. Because I view it as a health screen. It's not a blame, shame, guilt question. It's I want to know so that I can best manage you and prevent any further harm within you that could come on from the medical system. I want to know these things, and here's why. That's that idea of the common knowledge. I'm asking these questions because I want to make sure that if you're at risk, I want you to know that you're at risk. So the next time your back pain flares and you go to the ER, 61% or 60% of people are going to get prescribed opioids. I want you to be in control and say, hey, I am at risk based on this tool that my physio, my chiro, my PA, my whoever told me. So it gives the control back to the patient. That's the idea.
All right, then we have time for one more from Vicki Winston. Do you meet with the treatment team for those patients? And if so, what is the professional makeup of that team?
So short answer is no. We were trying to partner with New Hope, and the idea was that I was going to be on site treating patients, and it would function more like a multidisciplinary team approach. But long story short, business partners couldn't meet, and so I committed essentially to Alicia, who's a friend of mine, and I was invested in these folks that I just show up, and I don't have any lay of the land, but they've entrusted in me and have given me the authority to do so. So short answer is no. That's the long answer.
Okay, so now we're up to our next break. So again, it's going to be 15 minutes, and then we will come back at 5:30 for our last speaker.
Thank you, guys.